So this is a very interesting ECG where we can see that there is tachycardia. So when we can calculate, so the calculation for heart rate is very simple. What we can do, we can calculate a total 300 divided by number of large squares, or a total of 1500 divided by number of small squares. So when we see for small squares, uh, there are around 5 to 7 small squares. So the heart rate which is coming around is around 2 110. And when we are going for a large squares, the large square is around 1 to 1.2. So 300 divided by 1.2 is around more than 200. So in this ECG, it is very crystal clear that the heart rate is more than 200. Now, more than 200, we know is not capable of transmitting this much of large number of heart rate or heart impulses or sinus nodal impulses to ventricle at this much high rate, and so heart cannot cope up, and most of the time patients will have symptoms of palpitations, shortness of breath, syncope, sweating, uneasiness, and many of the patients may collapse as well. So this is a very typical ECG of a patient presenting with palpitation, syncope, dizziness, uneasiness, and diaphoresis, that is significant sweating, with such a huge heart rate. In this ECG, the heart rate was around 220 to 230, and it was all regular. It was all regular. So this is obviously the first thing that comes to our mind is whether it is VT or SVT. So that is supraventricular tachycardia or ventricular tachycardia. Now it is very simple. Whenever it is ventricular, the QRS has to be wide. The QRS has to be wide. So normal QRS is has to be always less than 0.12 0.12 seconds. It has to be always less than 0.12 seconds. And in this case, it is. So QRS is very narrow. QRS is not at all wide, because ventricles, whenever there is ventricular rhythm, then only QRS will be wide and it will be more than 0.12 seconds. So in this case, QRS is very narrow, very neat. So it is a short or narrow complex tachycardia. So it is supraventricular tachycardia. The rhythm is regular, so it is not AFib. So it is supraventricular tachycardia with the heart rate of more than 200. We can see that QTC is prolonged. It is around 515 millisecond. In males, it has to be around 417. In females, up to 460 milliseconds can be acceptable. So any person, any patient presenting with SVT, the first drug of choice or the first mechanism has to be carotid massage. So carotid massage has to give only on one side. It has to be given by the thumb, and we have to apply pretty good strong pressure over carotid. We should put that much of pressure so that our thumb should be starting to have some pain. Then only that pressure that we are applying is considered to be sufficiently good to increase the vagal tone, because more is the pressure put over the carotid sinus, more is the pressure generated. That then stimulates the vagus, and then that reduces the heart rate. That reduces the automaticity of the sinus atrial node, and then that reduces the heart rate. The other thing that we always have to consider is adenosine. The first drug of choice for SVT is always adenosine. So adenosine, there are some few things that we need to know is must. Adenosine, the dosage is 6 milligram IV. The very interesting thing is the action of adenosine is very short. It is less than 30 seconds. The half-life is only around 1 to 3 seconds. So within one cycle, the adenosine completely disappears from the circulation. So adenosine has to be given through a large vein, preferably central line, but most of the time patient will not be having central line because they will be presenting to casualty. So an intracath placed at elbow will do. So adenosine 6 milligram has to be pushed fast over a period of 1 to 3 seconds. It has to be pushed very fast and it needs to be flushed with at least 10 to 20 ml NS, and the hand has to be uh, kept up as soon as or kept up or elevated as soon as the adenosine is given by intravenous route, as soon as it is given. The second thing that we need to always remember कि adenosine simply reduces the sinoatrial automaticity, as well as it also increases the time duration at AV node. That is the reason why it will reduce the heart rate. The effect only lasts for less than 1 minute. So even if the patient develops cardiac arrest, this is completely reversible because after 1 minute, this ends. So what we can do, we can simply push 6 milligram. If patient's rhythm doesn't revert within a minute or two, 12 milligram can be pushed for the next cycle. We can again wait for 2 to 3 minutes. If the rhythm doesn't revert to normal, then again 12 milligram can be pushed. So maximum up to 30 milligram of adenosine is given. If it doesn't correct the rhythm, then we have to switch to some other drug. So which are the other drugs? The other drugs which can be used is diltiazem. Diltiazem is an excellent drug. It is a calcium channel blocker, and the drug that is used is 5 milligram. It usually comes in 25 milligrams of vial. We take this 25 milligram in around 10 ml NS, so we completely take around 25 milligram, and 5 milligram of this diltiazem is pushed slowly IV over a period of 1 to 3 minutes. So over a period of 1 to 3 minutes, we give 5 milligram of diltiazem. That should correct the heart rate, because most of the time it is an excellent drug to correct the SVT if adenosine fails. So dilsem can be again repeated after 5 to 10 minutes if the heart rate is not settled. If patient uh, continuously gets the SVT, then the third option can be cardron or amiodarone. Amiodarone also acts as SA node. It also acts as AV node. It prolongs the effective refractory period at AV node, and it prolongs the conduction at AV node. That is the way it can terminate the SVT. So it acts at both SA node as well as it acts at AV node, and it can terminate the SVT. The drug dosage for cardron or amiodarone is usually always like SVT only. 150 milligram of amiodarone can be diluted in 50 to 100 ml NS, and it can be given over a period of 10 to 20 minutes. Uh, it can be also given by rapid IV bolus over a period of few seconds as well. It can also terminate SVT. Now the problem with the amiodarone and dilsem are both can precipitate hypotension. Both dilsem and both amiodarone can cause significant hypotension, whereas adenosine usually never causes hypotension. So dilsem and amiodarone can cause hypotension. Other things are this dilsem is not given in patients with hypotension, congestive heart failure, or it is not given in patients where there is wide QRS complex, and it is not given in those patients where patient has WPW syndrome. Whereas this scamadron can be given to those patients who has wide QRS complex. So it can be given if the QRS is wide. It can be given if the patient has WPW syndrome. So whenever a patient is presenting with SVT, the first thing that we always need to do is carotid massage. We have to apply pretty firm pressure so that our thumb should definitely get pain while giving pressure over carotid sinus. The most important drug is adenosine, 6 milligram followed by 12 milligram followed by 12 milligram. It simply disappears from the circulation within 1 minute, so the action is very short lasting. So even if the patient gets cardiac arrest, we don't have to worry. It will get reverted over a period of a minute by its own, and it simply reverse SVT in almost 70 to 75% cases. If adenosine fails, then we have diltiazem or verapamil, which is an excellent drug, but diltiazem or diltiazem is not used if the patient has hypertension, congestive heart failure, white coarse complex, or WPW syndrome. Whereas a cardron, which is cardron, the one of the most important thing is for amiodarone half-life. The half-life is 3 to 8 weeks. That is the reason why this drug is used for prophylaxis of recurrent VT and recurrent VFL. In fact, this is the one of the most important or very rare drug which are shown to prevent the sudden cardiac death when used over a period of long time. But amidron, especially if it is used for more than 200 milligram per day, had shown to cause so many problems like alveolitis, pulmonary fibrosis, hyperpigmentation of face, skin burns, osteoporosis, so hypotension. These are very common problems which are associated with cardron, but usually the efficacy of cardron is excellent, and the half-life of the drug is 3 to 8 weeks, which makes this medicine one of the best medicine for prophylaxis of prevention of recurrent VTAC, prevention of recurrent ventricular fibrillation, especially in those patients who has reduced ejection fraction. So this is all about today's class. We'll meet again in the next ECG class.